Sorry for being late. One session was going on the second hall and I just reached here. So I need my slides. It's Dr. Vipul's slide right now. Can I have my slides? So we all are aware about diabetic pandemic. We all are treating diabetic in multiple ways, which are not available in many parts of the world. Some medicines we are not using because of the cost, some medicine because of the fear of hypoglycemia, some because of other side effect. But can you tell me which is the most underutilized medicine in the diabetic segment? Yeah, that's insulin, which is a basic pathophysiological defect, the secretion defect or insulin resistance or both combined in many patients are there, but still we are underutilizing insulin. Sometimes we blame the clinical inertia, sometimes we blame patient's fear, sometimes we blame the financial thing, but ultimately we have to take the responsibility that we, a clinician, we, a doctor, has to do something for the management of the patient with uncontrolled hyperglycemia. When patient has myocardial infarction, when patient has stroke, when patient has fracture, we don't have any option to treat. But when it comes to the hyperglycemia, we are ready to negotiate with the patient. And in our Gujarati language we say, that means a patient likes something and the food giver is giving them and we are negotiating in them. So let's talk about tracking the code, setting and adjusting basal and bolus insulin for optimal control. We are in 2024, we have 100 years of discovery of insulin. We are number one in many things in the world, including cricket now. Still, our population having diabetic control in terms of HbA1c is not good. These are some numbers that we are not proud of because we have suboptimal control of our hyperglycemia and HbA1c is more than 8 in almost all the studies that has been done. We all are aware that diabetes is a progressive disease. At the time of diagnosis of type 2 diabetes, almost 50% of the beta cells are not functioning. And when we talk at the end of 9 to 10 years, then more than 80% of the beta cells are not functioning. It is found in one study that after 3 years, patient will require more than 2 medicines to control their diabetes, but after 10 years, with the multiple OAD also, they will require insulin for better management of their hyperglycemia. Again, I would add in this situation that this is an ideal situation where patient has kept good control of their hyperglycemia for first 10 years. Then they will require insulin after a decade. But most of the people in India, we don't have good glycemic control in the very beginning of their diabetes as well. So what are the indications of insulin therapy? Yes, absolute indication is pregnancy, absolute indication is type 1 diabetes. But there are some comorbidities, there are some complications, there are some uncontrolled hyperglycemic patients who are intolerant to OHA. There are some patients who are using corticosteroid. In those patients, insulin is almost required, but we are somehow not using either insulin or not using them adequately for the management of their hyperglycemia. This is a 100-year history of insulin. We have started from bovine insulin, we have the recombinant insulin, then we have analog insulin, we have the fastest acting insulin which can start working within 1 to 2 minutes, and even we can give them post meal also. And now we have the longest acting insulin which we can give once a weekly. Still the glycemic load of the diabetic patients are not well controlled despite of 100 years of insulin discovery. These are some new preparations of insulin that are available, but I am not going into detail because I want to more focus on the dosing of insulin. How we should give insulin? We should try to give insulin that mimics the physiological release of insulin. In the body, from the pancreatic beta cell, insulin is released in 2 phases. One is a basal insulin, which is a continuously secreting in response to hepatic glucose production and in response to the glucagon level. And second is a bolus insulin, which is secreted in the response of glucose that we eat in our meal. So let's take a 3 scenario. One is a fasting sugar, second is a post meal sugar. What should we do when we start insulin? The fasting sugar is high and post meal sugar is also high. Then we have to take that whether the gap between fasting and postprandial is high or not. If the gap is not that high, we have to start with the basal insulin, and basal will bring down the fasting sugar as well as the post meal sugar, and the glycemic control will be fine. But if the gap is too high, the fasting is high, PPBS is also high, the gap is very high, then we require a basal bolus therapy in that patient for better control. And in the last situation where the fasting is under good control but PPBS is very high, at that time we require 1 or 2 prandial shot of the insulin for better management of type 2 diabetes. The gold standard for the management of diabetes in terms of insulin therapy is basal bolus therapy, in which we give one sort of long-acting insulin which covers a 24-hour glucose profile and multiple sorts of short-acting insulin in each and every meal that patient is consuming. So this is a basal bolus regimen in which the red line is showing a basal insulin, long-acting insulin, here the name is written glargine, and second is a short-acting insulin which is given before breakfast, before lunch, before dinner, and if any other small meal is taken at that time also we are giving in terms of either Lispro or Aspart, that is covering the bolus part of basal bolus regimen. Now let's see what the guideline has to say. Almost all the guidelines I am stating RSST and ADA that says the absolute indication is type 1 diabetes. Second is a hyperglycemia despite of maximal tolerated OHA. In this population we have to give insulin also in perioperative patient, also in transplant patient, also in critical care unit patient, perioperative, preoperative, postoperative patient, pregnancy and patient with severe renal as well as hepatic impairment patient, we have to give insulin. Again, in some situation when patient has a decompensation like acute injury, severe stress, severe infection, patient is having complications like decay, HHS, patient is losing weight because of insulinopenia, and patient is on certain medicine like corticosteroid, these are some indications for insulin therapy. And ADA 2023 also saying that starting insulin is not sufficient, we have to intensify the injectable therapy. Like setting up a match and we are sending Rohit Sharma and Virat Kohli in opening, but we are not telling them whether it is a T20 match or test match or 50-over match, they will not perform accordingly. So let's start with the dosing of basal insulin. We can start basal insulin by 3 means. First, a standard dose that you start with 10 units at a fixed hour of a day, and then monitor fasting sugar every 3 days, and according to fasting sugar you can up titrate or down titrate that dose. Second possibility is go according to the glycemic load. See the patient's HbA1c whether more than 8 or less than 8. If the A1c is less than 8, you can start with 0.1 to 0.0 unit per kilogram of the body weight per day in the patient, and if the HbA1c is more than 8, you can start 0.2 to 0.3 unit per kilogram of body weight per day, and then according to fasting sugar every 3rd day you can up titrate or down titrate. Let's see, in a drug insulin naive type 2 diabetic patient we have started insulin because fasting sugar goal will be different in different individual according to their comorbidities and complications, but drug naive without any complication we keep the target of 80 to 120. If the fasting sugar after 3rd day is more than 120, we have to increase the dose of basal insulin. If it is between 110, 120 to 130, we can increase 1 unit. If it is more than 140 to 180, we can start 10% of the total daily dose in terms of increasing the basal dose. And if the fasting sugar is more than 180, we have to increase the dose of insulin by 20% of total daily dose, and this has to be done until the fasting sugar is set between 80 to 110 for your type 1 diabetic type 2 diabetic patient. The ADA is also recommending the same, start with 10 unit or 0.1 to 0.2 unit per kg per day and then up titrate accordingly. Now, when to move from basal only to basal bolus therapy? Obviously, in type 1 diabetic patient, second patient with having insulinopenic syndrome, third is a patient having severe hyperglycemia despite of only basal insulin, and fourth when the other OHAs are contraindicated. So how can we start the basal bolus therapy? Now patient is on basal therapy, fasting are fairly controlled but post meals are not controlled. So first we have to see whether one post meal is uncontrolled or 2 or all 3 are uncontrolled, and according to that we have to start the insulin in the pre-meal that have maximum uncontrolled sugar. We can start again with a 4 unit of bolus insulin, or we can start off 0.1 unit per kg or 10% of the total basal dose. Either of them you can use, and then depending on the postprandial blood sugar on that day, from the next day we have to up titrate or down titrate the dose by 1 to 2 unit, and again if the sugars are less, we can reduce the dose of prandial insulin as well. So indication of basal bolus therapy: severe degree of hyperglycemia with complication, without complication, symptomatic patient, either osmotic symptom or weight loss or catabolic state, or asthenic patient, secondary diabetes because of drug induced like corticosteroid or immunosuppression, pancreatic diabetes because of pancreatectomy or some disease of pancreas, or some endocrine disorder like Cushing syndrome or acromegaly, sick diabetes, patient having acute complication, acute comorbidities, or having immunosuppressant or steroid use, and special situation like pregnancy, renal and hepatic impairment. So if the HbA1c is not under target, it is our role to control them. We can start with the basal insulin, we can start with the basal bolus, or even co-formulations are available with which, according to RSSDI, we can start with combination therapy. This is the ACE 2023 insulin therapy chart, and again it is stating the same, that start basal insulin if HbA1c is uncontrolled. If it is less than 8, start with 0.1 to 0.0 unit per kg. If more than 8, start with 0.2 to 0.3 unit per kg. And every third day do fasting sugar, and according to that up titrate the dose of insulin and reach the goal of fasting plasma sugar. If the glycemic control is still not good with the basal only the insulin, start the intensive therapy with prandial control. You can have basal plus 1 salt, basal plus 2 salt, or basal plus 3 salt, and basal bolus therapy for better control. Again, start with the 4 unit or 10% of the basal dose of total daily dose, and according to the post meal sugar, up titrate and down titrate the insulin therapy every third day. So patient-centric basal bolus up titration and down titration strategy, it is also given in a simple way, that target is 80 to 130. If it is less than 80, reduce the dose by 2 units. If it is 131 to 160 plus 2, 161 to 180 plus 4, and it is more than 180, you should increase the dose by 6 units. We can use a premix insulin that I and our team don't recommend. We can use a basal insulin and basal bolus therapy for the optimal control and gold standard for the therapy. With that, I would say thank you to all for silent listening, and it is a workshop, so we can have question answer.